Hi and welcome back to another video of Medic Notes. This video is on pelvic ring fracture. Pelvic ring fractures are high-energy fractures of the pelvic ring which typically occur due to blunt trauma. Diagnosis is made radiographically with pelvic radiographs and further characterized with CT scan. Treatment is typically operative fixation depending on degree of pelvis instability, fracture displacement and patient activity demands. For anatomy, starting with osteology. The pelvic ring is a ring structure made up of the sacrum and two innominate bones. Its stability is dependent on strong surrounding ligamentous structures. Displacement can only occur with disruption of the ring in two places. Neurovascular structures are intimately associated with posterior pelvic ligaments, and there is a high index of suspicion for injury of internal iliac vessels or lumbosacral plexus. There are many associated ligaments nearby. Anteriorly there is the symphyseal ligament, to resist external rotation. At the pelvic floor, there is the sacrospinous ligament to resist external rotation, sacrotuberous ligaments to resist shear and flexion. The posterior sacroiliac complex is the strongest ligaments in the body, and is more important than anterior structures for pelvic ring stability. Anterior sacroiliac ligaments resist external rotation after failure of pelvic floor and anterior structures. Interosseous sacroiliac resist anterior-posterior translation of pelvis. And posterior sacroiliac resist cephalad-caudad displacement of pelvis, whereas iliolumbar resist rotation and augment posterior SI ligaments. For neurovascular, common iliac system begins near L4 at bifurcation of abdominal aorta. External iliac artery courses anteriorly along pelvic brim and emerges as the common femoral artery distal to the inguinal ligament. Internal iliac artery dives posteriorly near SI joint and divides in the posterior division, giving of superior gluteal artery. And anterior division becoming obturator artery. Corona mortis is a connection between the obturator and external iliac systems. Venous plexus in posterior pelvis accounts for 90% of the hemorrhage associated with pelvic ring injuries. Whereas for neurology, the lumbosacral trunk crosses anterior sacral ala and SI joint. There are two groups of classification for pelvic ring fractures. The first one is tile classification. A is stable. A1, fracture not involving the ring. A2, stable or minimally displaced fracture of the ring. And A3, transverse sacral fracture. B is for rotationally unstable and vertically stable fractures. B1, open book injury. B2, lateral compression injury. And B3, which is bilateral. Class C is rotationally and vertically unstable. C1 is unilateral, C2 is bilateral with one side B and one side C. C3 is bilateral with both sides C. The other classification is the Young Burgess classification. For APC, anterior-posterior compression. APC1 is symphysis widening less than 2.5 cm. APC2 for symphysis widening more than 2.5 cm. Anterior SI joint diastasis. Posterior SI ligaments are intact, or disruption of sacrospinous and sacrotuberous ligaments. APC3 include disruption of anterior and posterior SI ligaments, disruption of sacrospinous and sacrotuberous ligaments, or associated with vascular injury. For lateral compression, LC1, oblique or transverse ramus fracture and ipsilateral anterior sacral ala compression fracture. LC2, rami fracture and ipsilateral posterior ilium fracture dislocation. And LC3, ipsilateral lateral compression and contralateral APC. There is also the vertical shear, with posterior and superior directed force. For clinical presentation, symptoms are pain and inability to bear weight. On inspection, test stability by placing gentle rotational force on each iliac crest. Look for abnormal lower extremity positioning. Look for external rotation of one or both extremities. Limb length discrepancy. For the skin, look for scrotal, labial or perineal hematoma, swelling or ecchymosis. Flank hematoma. Lacerations of perineum, or any degloving injuries. For neurologic exam, rule out lumbosacral plexus injuries. Do a rectal exam to evaluate sphincter tone and pararectal sensation. Do a urogenital exam to look for gross hematuria. And vaginal and rectal examinations are mandatory to rule out occult open fracture. For radiograph, we usually do AP, inlet, and outlet views of the pelvis, shown in these three pictures respectively. Look for radiographic signs of instability, such as more than 5 mm displacement of posterior sacroiliac complex, presence of posterior sacral fracture gap, or avulsion fractures. We can also do a CT scan as a routine evaluation of the pelvic ring. It provides better characterization of posterior ring injuries, helps define comminution and fragment rotation, visualize position of fracture lines relative to sacral foramina. The radiographic signs of sacral dysmorphism include anterior up-sloping upper sacral ala, irregular, non-circular, sacral nerve root tunnels, residual S1 disc, and tongue and groove SI joint. For treatment, resus the patient, apply pelvic binder or sheet. External fixation and angiography or embolization if indicated. The treatment is different based on the classifications of the pelvic ring injury. For APC1, non-operative, we just apply protective weight bearing. Whereas for APC2 and 3, anterior symphyseal plate or external fixator, and posterior stabilization. For LC1, majority of cases are non-operative. Whereas for LC2 and 3, operative treatment include ORIF, or posterior stabilization. For the complications, urogenital injuries like posterior urethral tear or bladder rupture, neurologic injury, DVT and PE, chronic instability, and infection. That's all for this video. Thank you.